Hi everyone, I'm Jeremy and this is Dr. Wilson. We're from Phoenix International Stem Cell Clinic. And so today we're going to approach a relatively complicated question. Why are some treatments accepted and popular while others are called experimental? Now, the line is a lot thinner than that people probably think. So, Dr. Wilson, why is it that we practice that some procedures we call experimental and others are called accepted, while the evidence to them might be pretty much the same?
That's a good question, and I think we're going to begin by saying that, in every case, as doctors and as healthcare professionals, we're doing our best.
Yeah.
And a lot of the time, what you learn in the beginning, your foundation is really what you build upon.
Yeah.
And so, for a lot of professionals particularly within our field, the musculoskeletal field, people have been learning the treatments, and this is what we did when I was learning, so that's what we will do.
Yeah.
And it takes a lot to drag a person from their fundamental basis and get them to somewhere new.
Exactly.
And
right.
I mean that. We find it in all walks of life.
Yeah, we're human beings, and as human beings, we like what we're used to. We're all creatures of habit. So we work with orthopedic surgeons, neurosurgeons, physiotherapists, sports doctors, chiropractors, general practitioners every day. And so we definitely don't want to give the impression that we're being critical, because we're not.
No.
We're all trying to do our best, and we don't know a single person working in the healthcare industry that doesn't want to genuinely help their patients. But exactly like that, we're tied to tradition. Yeah. So an example we often use is knee surgery and meniscal surgery in general. Now, meniscal surgery has been done since 1970 or 1970s, but unfortunately that wasn't researched or started research to the early 2000s, and by the 2010s we were starting to find that the research wasn't that positive at all. In fact, it was actually showing that it was making things worse rather than making things better. Mm-hmm. Now, the problem is then people would ask us, well, if it doesn't work, why are specialist surgeons doing it? Why are they paying for it in hospitals?
Mm-hmm. And again, another good question, and that is a lot has to do with the environment you're in. As a specialist, it's easy to start to see the patterns where, in particular, in the case of meniscal surgeries, the first year to 2 years, people were improving. The problem is that the 5-year results show that they had a worse outcome after 5 years than if they hadn't taken the surgery. So, and a surgeon, as a general rule, won't need to follow a patient up for 5 full years.
No.
So they were seeing the initial honeymoon period and thinking, this is amazing. All my patients are so happy, and making a good judgment call. If it hadn't been that after extra years where they weren't being seen again by their orthopedic surgeon, the results started to fall off. And then, of course, we are sometimes a little bit too married to our preconceived notions, where if I see someone and I've treated them and after they come back and maybe in 5 years they're worse than they would have been without the treatment, it's hard to look at that completely objectively, because in your head you think, okay, but it's natural to get worse because they had a problem before, they're going to fall back, they're going to relapse.
Yep.
And of course, it's only when you actually have data that you can sit down and analyse that it's easy to then look back and say, oh, this wasn't as good as we thought it was.
Exactly right. And that's the thing, that we only see each other's sort of failures, if you get what I mean. I don't see the patients that go and get operated on for a disc that are great. Otherwise, what were they doing in my clinic? I see the ones that weren't surgical candidates or had poor outcomes after surgery. The same with knees, same with shoulders. And so we're always a little bit biased in that. But when people talk about experimental and talk about accepted, those two can be very different things. What happens is, if you have a body of professionals that believe in one thing, we like to hang out with likeness people, okay? It happens in all walks of life. So suddenly we start accepting that things are just fact. So, and we could go very political on this, so we could go with environmental change, with political parties, but it tends to be that we form people that have like-mindedness to us, form together, and instead of analysing things independently or very objectively, we let our objectivity, because we're human beings, come in the way. So a lot of times things become accepted and popular because enough people like the idea of that before it was actually proven. And now in some cases that's been really good. It means that we've been early adopters and things went really well. In other cases, it's quite the opposite. It means that we should have waited before more evidence to come before we did it. Now, a big thing to remember in modern medicine comes down to risk. Is it more acceptable to do something experimental if the risk is lower than if the risk is higher? Do we need more evidence to implement the procedure?
Yes, is the simple answer. We definitely do. And actually, that's part of the reason why we feel confident in offering our experimental treatments to patients. And the reason it's called experimental is because there are no good randomized control trials looking at this over time. But just to mention a quick aside, if you were to look for a randomized control trial for a knee prosthesis, and knee prosthesis is one of the world's most often performed orthopedic surgeries, you're going to find one. And that was published in 2015 by a Danish doctor called Skau. And he wrote about 100 patients who they followed up in a randomized control trial. So both of those treatments then could be looked at as likewise experimental. And we're absolutely not going to stand here and throw stones, because people in glass houses don't throw stones.
No.
And we're all in glass houses, quite frankly, as doctors in general, because a lot of the data we're basing ourselves on either is older data or it's maybe incomplete for all cohorts or all groups of people. It's very hard to find a study that actually includes everyone. And that's where then once you get to very well established science, you get what's called meta-analyses. And that's where you then look at, here we have 10 randomized control studies, and this randomized control group has actually made 10,000 people. So, this is amazing. That gives us evidence we can stand on forever. We don't have that.
No.
Orthopedic surgeons, unfortunately, probably don't have either.
That. No.
And an awful lot of medicine doesn't have the gold standard. But what we do have is we have confidence in that when we give our patients treatments with stem cells, we are using their own body's tissues for their body, and it is safe. Yep. You cannot get a rejection. No. You cannot get an allergic reaction. Any medicine can give allergies. You're not getting medicine. You're getting your own body's best cells put where you need them.
Yeah, and that's exactly right. That's the thing, is that if we would assess everything if everything that is not proven by multiple randomized controlled trials to a high degree with many people, unless you have that, it's experimental. If you think of the thing so black and white, basically everything, I would say everything is experimental. The newest guidelines from international spine treatment, so that's back pain and interventions, was done about a week and a half ago, and that was published in a really high impact factor journal in the US. And they actually assessed all the treatment of what's currently been done for back pain and the level of evidence that came with it. It was a great study, but basically it said that 99.9% of everything that's practiced has inconclusive evidence to its efficiency. Now, does that mean we stop doing everything? Absolutely not. Does it mean that we have to keep researching? Absolutely. Yeah. It just means that we need to take things with a grain of salt. And while some may say this is experimental, and this is experimental and maybe dangerous, that's the difference that has to happen, okay?
Yeah.
Like we say also too, we're massively on that we need to do more research, and that's part of our clinical practice is researching this stuff. But we want to again highlight that we don't want to throw stones. People are doing the best they can, and we really applaud everyone working with us. But it's really important to compare oranges and oranges and not hold a intervention to a higher standard of evidence just because it's new. Okay, if we're going to do that, then we need to do it with all medicine and with all interventions, and that won't end well for lots of interventions. Okay, as normal, if you've got any questions, please comment down below. If you want to talk to us directly, please go onto our website, www.phoenixstemcell.eu, and in there you'll get some links to talk to us directly and tell us about you. But otherwise, enough for us today. Have a great day.
See you later. Bye-bye.